In this video, we're going to be going through some of the 5 key signs and symptoms to try and identify whether your pain is actually coming from the hip joint in particular. So if that's you and you're thinking, am I getting pain because it's my hip joint? Well, this video is going to hopefully help you clarify that. Now, hip pain is a huge burden on the whole world, right? And look, I'm biased. I love hips. I'm a passionate hip specialist. That's all I like. I'm a one-trick pony, guys. One-trick pony. Hips are my thing. But I can see the amount of impact and burden it has on so many people. And we have to try and improve the outcomes. We have to try and understand how we can help people better. And really, it starts from the foundations. It starts from the basics of really trying to identify whether or not someone's hip pain or symptoms are coming from the hip joint. So I'm going to give you some 5 top things that you need to consider. But before we jump into that, I need to highlight the fact that the hip joint itself can be quite vague with where the symptoms are. Now, commonly, hip symptoms or location of symptoms doesn't really tell us enough. And that's the first thing I want to say, because the location of pain for the hip joint is interesting. Now, commonly, most people will get groin pain, or they'll do this C sign, where they'll do this with their hand, kind of put it to the top of the hip. And you say to someone, like, where is your pain? Where are your symptoms? And they'll say, oh, I'm a bit unsure. It's kind of in the groin, or it's kind of, you start moving the leg around and do this with the top of the pelvis and you can't really tell. Well, that in itself is a symptom. That in itself is part of that narrative, a very common theme and kind of insight that we get from patients who have hip joint pain. And then it's the nature of that pain. You know, it's like, well, is it constant? Yes, but also mechanically there are certain things that provoke it. Mechanically there are certain positions that make it feel worse. And when we start to identify that, then we know that we might be in the right ballpark. Because as a clinician, when you're standing in front of us and we're trying to identify where your symptoms are coming from, and realistically at that point, it's a case of trying to think of, well, is it the hip or is it not the hip? Because we need to start at that absolute rudimental level to be sure we know what's going on. So first, the sign, the symptoms, and kind of like where the pain is. And we've said that, so groin pain, C sign, and that level of vague type, I'm not really too sure where the pain is, but it's really sore. Now, interestingly, hip joint pain, in particular the arthritic hips, right? So in particular, hip osteoarthritis will present and potentially give symptoms a little bit lower down. You could have an arthritic hip and have no groin pain. You could just have vague thigh pain. You could even only have knee pain. And that's the thing that starts to send people down the rabbit hole, because you think, my knee hurts, it must be my knee. Well, that's not always the case. Use your lower back as an example. People with sciatica sometimes only get calf pain, only get leg symptoms. They don't get any back pain. It's no different with the hip. So you got hip pain, and if you think you've got an arthritic hip or hip symptoms, don't focus just on the groin, just on the hip. Sometimes symptoms that you might be disregarding lower down the leg may well actually be part of that same presentation, may well be part of that same picture. So the location, that's the number one thing. But we know, and I've just said, that doesn't tell us enough. So we got to figure out those other things. Remember, I said I was going to give you 5. I've only given you 1 so far. So hold your horses. We haven't diagnosed it yet. The other one is now we have to start getting into signs and symptoms. And one of the key features, especially with an arthritic hip, is early morning stiffness. Now, early morning stiffness is really key to understand, because hips, and in particular that hip joint that started to deteriorate into an arthritic hip, will commonly have worse pain in the morning. The hip will feel stiffer in the morning, and generally that's a theme that we would want to identify to help think whether or not someone's pain is coming from their hip joint, in comparison to the patient who has like a tendon related problem or a muscle strain. Like, it might be a bit sore in the morning, but it's not going to be such a distinct, obvious theme. Now here we've got a joint, it just doesn't like to be sedentary. The joints generally like to move. Now, you're not going to move any less than when you're in bed, hardly moving, dead asleep. And then you wake up, you're trying to get out of bed and you're thinking, oh, gosh, it's going to be a bad day. But it's just how that presents. It's just part of that presentation. So early morning stiffness is an absolute number one thing that we need to ask our patients. But you've got to consider the fact that when I'm talking about hip joint pain, it may not always be an arthritic hip. Hip health has a wide spectrum. You've got severe arthritis on this end, and then you've got like moderate, mild, you've got the precursors to arthritis like subchondral cyst, bony edema, some reduction in joint space. And then over here, you've got the precursors or the risk factors for an arthritic hip. FAI syndrome or hip impingement and hip dysplasia. And sometimes those patients who have FAI syndrome or hip dysplasia that still have hip joint pain, well, they may not well get the early morning stiffness. They may well not get that kind of all the way the symptoms lower down in the leg. They may just have mechanically induced groin and hip joint pain. So aside from the fact that we now know that, well, it could be the hip joint because it's not an arthritic hip, or it could be an arthritic hip, we have to then dial into those mechanisms and the mechanics or the aggravating factors that will help us consider and understand more whether or not the symptoms are coming from the hip joint. And that brings me on to point 3. Now, point 3 is an absolute cardinal telltale sign of someone who has an arthritic hip, or in particular those who have hip joint related pain. And I'm talking about difficulty putting shoes and socks on, difficulty putting socks and cutting toenails, or even washing feet. And it's that mechanically induced difficult movement that patients always, especially within the arthritic hip population, tell us that they struggle to deal with. And we're talking about real fundamental, obvious tasks that day to day you wouldn't even hope to think twice about. And in this situation, you're thinking, forget the inability to walk or use stairs or do things functionally because my hip hurts. Well, now I can't even lift my leg up. Forget, initially you start to think sitting cross-legged was a little bit difficult, that was a bit stiff, and now actually thinking I'm struggling to wash my feet, I'm struggling to cut my toenails, putting your shoes and socks on, I'm starting to be really awkward. You're kind of having to think in awkward ways, in different ways to try and compensate for it. That's not normal. There is obviously a change going on. But like I said before, depending on the health of the hip, which fits quite a wide spectrum of things that it could cover, that would then contribute to, well, how difficult you find these tasks. And when we're starting to talk about patients who are suitable candidates for surgery, in particular like for a hip replacement, these are the questions that we'd want to know, because all those things impact your quality of life. It brings me on to my 4th point, which is another functional limitation that patients commonly with hip joint related symptoms would struggle with. And again, it comes down to movement, and that's getting in and out of a car. Such a fundamental basic thing, but it's a struggle because you have a hip joint, right? And in particular, like I said, on that spectrum of even if it's like moderate to severe type arthritic changes, you have a hip joint which has a lack of movement because it's stiffening up. And that loss of range of movement in the hip then means that functionally when you're doing these tasks, like getting in and out of a car, putting your shoes and socks on, cutting your toenails, are difficult because the hip just isn't moving. So when you've got a hip that isn't moving because of what's happened, then getting in and out of a car, it sounds so simple, but it's a big thing that you can't do because you cannot move the hip away from you. Brings on your pain, and that deep ache pain that you have might actually be quite an acute, sharp pain when you're trying to do these functional tasks. Now remember, I said to you, we're just trying to figure out, is it the hip or is it isn't? If it isn't, well, at this stage, you're thinking the symptoms sound like it could be, the locations sound like it could be, but the movement, the mechanics, and the aggravating factors are making it really hard for me to refute the possibility that it isn't the hip that's driving it. And that's a big, big thing that you need to consider, because all of these key signs and symptoms are absolutely textbook when it comes to someone who has a hip joint related pathology. But like I said to you before, that spectrum of hip health isn't going to be just the arthritic patients who will give us these unique signs and symptoms. We also have the younger adult population who may have the hip dysplasia, who may well have the hip impingement. And with these patients, they also have their nuance, their own like unique signs and symptoms. And one of the things that these hips don't particularly like, and this is the 5th point that I want to touch on, is they may not necessarily have the significant loss of range of movement that you would have with your patient who has an arthritic hip, albeit there might be a bit of stiffness. But what you do have is an ability to refute that possibility, because these hips struggle when the hip is being brought to the chest. So the hip to chest, that deep flexion, can be quite sore, can be quite painful. Pulling the hip across your body with a flexor, bringing the knee to chest and across your body and rotating the hip, can be really quite provocative and quite painful. Now, these aren't clinical tests that enable us to diagnose anything other than telling us that, well, it could be the hip joint, and because those movements are painful, I'm not being able to refute that possibility. But again, it comes down to movement, mechanics, and things that stress the hip in a way that provoke symptoms. These are real important things to consider, because the biggest pitfall when I see patients present with hip pain or present with symptoms that are because of the hip joint, their biggest downfall is when they see someone or they get told that, well, actually your symptoms are you've got a tight hip flexor, you've got a weak hip flexor. Why do they get told that? Because your hip flexors are at the front of the hip here. And commonly, I said to you, number one, people who have hip joint pain will present with groin pain or pain at the front of the hip in exactly the same area anatomically to where your hip flexors are. So it's really simple, really easy to say to someone, your hip flexors are tight just because their symptoms are there. But I've just said to you also, well, these different types of hip conditions at whatever level may also present with symptoms in exactly that same area. The problem is managing someone or giving someone exercises and stretches for a hip flexor, well, that can sometimes irritate that person who actually has hip joint related pain. Now, what I want to caveat with all of this stuff is, however, look, I'm being a hip specialist and expert for over 13 years. I've been a physio for 16 plus years. I trust that the advice that I'm giving is based on the fact that this is my area of expertise. But I tell you what, even with videos that I'm presenting to you now, you can't use this as a way of diagnosing yourself. If this is just ways to educate, if you think some of this resonates, I think this sounds a little bit like what I've got, or actually I've had a similar experience and I want to share that. Well, one, I would want you to comment and let others know so people can kind of learn from your experiences. But two, if you're unsure, find a decent clinician, see someone that you can trust, see someone that deals with these things a lot, and get some decent input and go from there. But comment, I want to hear from you. I want to hear your experiences if some of this stuff makes sense and if it resonates. Well, hopefully it all makes sense.